Some of these are highly engineered molecules might have higher immunogenicity, which could theoretically affect dose, efficacy, and potentially even toxicity. I'm wondering, for the other abstracts presented, Dr. Albrigez, Dr. Middleton, and I think Dr. Wong is not able to join us, was immunogenicity looked at in these studies or in earlier studies of these agents, and do you think that could have a contributing effect to the results you're seeing?
I can answer for Tepenzifus. We looked specifically for it in the phase 1 and saw no evidence of immunogenicity across repeated dosing, despite the tachyphylaxis that we saw with the CRS-type symptoms with successive doses.
Yes, similarly, it is still under investigation, given that we are enrolling the last cohort in this study, so this data will be generated.
And maybe I can ask, there is a question online that alludes to this, but I'm going to just expand this question a little bit to Dr. Rini. You alluded to the fact that the toxicity for MEDI5752 is not that different than Ipi-Nivo, but you also sort of talked about the potential enhanced binding kinetics leading to increased cytokine expression. Maybe that's why we were seeing increased T-cell proliferation. Do you think there could be, and this is maybe a question for all of you, do you think there could be an opportunity for increased toxicity with biospecifics as a result?
I think there could. I mean, I think the jury's still out, and clearly the MEDI1572 started at higher doses and had to come down. And as I said, we see a hepatic signal that we really don't see with Ipi-Nivo some, but again, small numbers. So I think the jury's out, but I think it's possible.
Okay. Anybody else want to weigh in?
Well, I think for the TCR-based therapeutics, it's very much about the specificity of the target. And certainly a big consideration for us with TEBI was that there are a couple of normal tissues where GP100 expression is seen, including in the retina. So we had lots of concerns about whether that might be a factor. But interestingly, it really is only the level of expression seen in normal melanocytes and therefore rash that's been a consideration with that. And so, it is on-target toxicity, and therefore with the TCRs it comes down to where else is that target. And sometimes you get unexpected observations with that, certainly in some of the earlier agents that were used in slightly different technologies from the Intacs.
There is, I don't think there's anybody at the microphones yet, but there are some specific questions from the audience, particularly to Dr. Schramm, around the two targets that are being targeted by the bispecific HER2 and HER3. One, I think they're both related. One, since HER3 is the preferred heterodimerization partner for HER2, should zenocutuzumab work in HER2-positive cancers regardless of NRG fusion? Is this being investigated in HER2-positive cancers, and is that something of interest not only for across tumor types, particularly breast cancer, but in the non-small cell lung cancer population that you were looking at?
Thank you for that question. So in this phase 1 study of zenocutuzumab, actually the initial clinical development was focused on HER2-positive cancer. So the trial at this point has been focusing on HER2-positive gastric and breast cancer, and those results have been presented and published. With the discovery of adjuvant agents, it's really interesting niche and significant clinical need. The development has shifted after the initial development paradigm. That being said, I know Maris is interested in exploring other opportunities for their drug, and so I really think part of that is the ultimate clinical development plan, but it is a rational biomarker. Yeah.
Thank you.
Can I add?
Yeah.
No, I think it's actually very interesting that all the drugs that are being currently in development for these tumors are actually repurposed drugs. So, I mean, until now, we don't have drugs that have been developed for targeting NRG1. They are all drugs that were developed otherwise, and then we found the alteration, and we are trying to see the activity.
Yeah, I agree. Actually, maybe as a follow-up to that, could I ask, you did show that the majority of patients had some amount of tumor regression. Was there anything specifically looked at in the difference between those who had frank progression? Is there a difference in NRG1 levels or the fusion partner that you think can be influencing the response here? Or because it is receptor binding at the antibody surface, do you think those aren't playing a role?
Yeah, that's a great question, and one that we're really interested in figuring out. In terms of the ability to predict the responders or the non-responders, or those who benefit versus those who don't, it's an area of active investigation. So far, there have been, as you saw, many different fusion partners enrolled on the trial. 15 different fusion partners benefit. So I think the data is still too early to analyze in a fusion partner specific way. Whether genomic alteration or patient or histological characteristics may predict ultimately for clinical benefit. It's something we're really interested in looking at. We have attempted to get serum levels of NRG1 for ELISA, which we kind of alluded to in terms of the ultimate level of NRG1. Although preclinical models have suggested that the mechanism of action is such that even in vitro calculating levels of NRG1 ligand, the antibody competes NRG1. So we think that this should be effective even at very high NRG1 levels. So all of that is another exploration, and it would be great if we could have even better biomarkers for this stuff.
Microphone 3.
Yes. So is any kind of biomarkers we can use to predict the efficacy or the toxicity of the bispecific antibodies?
Yeah, I think that's a question for anybody up here. Maybe we can go down the line and see what you think about that.
For the TCRs, the targets, we moved from cutaneous to uveal melanoma based upon clinical outcome, but also the expression of GP100, which is almost ubiquitous in the uveal form of the disease. So I think that's probably the key biomarker. There are more subtle ones, but they tend to be ones that we observe on treatment rather than pre-treatment, so they're not a good basis for selecting people for treatment.
So I think that this should be tackled in two different ways. The first one would be to apply what has already been generated with, the two approach being combined as co-administration, and therefore PD-1, among others, will be looked at. On the other hand, and given that we believe there is an underlying benefit that may be different, especially for, long-term sustained PD-L1 inhibition in those patients, given the administration over time of this agent, I think we should have a de novo approach and considering to develop new biomarkers specifically for these ones.
Yeah, I'd just say, I guess the question is the biomarker for bispecifics going to be different than a biomarker for each drug administered separately? In kidney cancer, PD-1 is not a useful biomarker. It actually enriches for response to Ipi/Nivo, but PD-L1 negative patients have a survival advantage as well, so we don't use it clinically. I don't know why it'd be different for bispecifics, and Dr. Wang presented data that PD-1 the status didn't matter in her study, so I think it remains elusive as usual.
Yeah, I think that's a good point you bring up about Dr. Wang's presentation. So I think PD-L1 does have some predictive value for PD-1 targeting agents in cervical cancer, and I don't think it's so clear maybe for the combination, but I think I guess the question is, especially for that kind of scenario where there's multiple things being combined, what is the right approach to thinking about biomarkers for these, and how you alluded to we need a de novo approach. How would you go about that? And do you think it's going to be the two different targets themselves or something completely different as a downstream of immune function that would be a biomarker?
I think it's an open book, honestly. We do need to develop this research. Obviously, these are early ages of this agent, and therefore we do need both a blood-based approach, a tissue-based approach within all of these trials.
Thanks.
Thanks.
Microphone 2.
Thank you. This is a question for Dr. Middleton and Tebby. So given that PFS and response rate are not necessarily indicative of clinical benefit, what should physicians be looking for when considering switching a patient off of Tebby, given the OS data is so strong?
Well, I think it was relatively straightforward in the uveal setting where there was a dearth of alternative options. But if one moves into cutaneous melanoma, it is more complicated. But we've been there before with ipilimumab, which has a response rate of about 14% as a single agent and durable benefit in nearly somewhere between a fifth and a quarter of patients, so substantially higher than that. The patients who progress and tend to stay on treatment look as though they're certainly not deteriorating. They're tolerating the treatment well. They're holding their own. And therefore, it's a relatively straightforward decision to carry on. I can't think of any instances in my personal experience with the agent where it's been a difficult one or where we have carried on perhaps more in hope than expectation. I think the real interest which Dr. Geralda raised is whether the sequencing is quite right yet. This idea that you need more time with just the Tebby before you give the PD-1 agent is kind of interesting, but that's perhaps a separate issue, not speaking directly to your question. But as I say, it's clinical benefit and clinical judgment, I'm afraid, which is good news for clinicians. We're still needed.
Thank you.
There is a question which I'll just fold into maybe my last question for everybody up here, which is, when you create bispecifics or multi-targeted molecules, which might include more, you're balancing a number of different things, the affinity for the two different targets, how you're going to look at biomarkers in a unique way, and how you're going to differentiate activity and toxicity from combinations. I'm wondering what you think about bispecifics, which are still in a new field, but and as a gateway drug, if you will, to multi-targeted or higher order trispecifics, other kinds of things that bring in two targets in the tumor or two immune targets with a tumor antigen target, and whether you think we will continue to see potential benefit by doing multi-targeting, or whether the complexity and the difficulty might make that something of diminishing returns.
Everybody backed away from the microphone. I don't know. I think the jury's still out. I mean, I think, in oncology, we're always facing a challenge of in whom do we intensify therapy and whom can we de-intensify. Now, in kidney cancer, we have that discussion all the time, and we still don't know, right? And I'm sure there are subpopulations where that triple blockade, et cetera, that sort of intensification will be a good thing, and others where you may not want to do that, right, where it could lead to increased toxicity. So I think that may be one of the particular challenges of this field, of this bispecific or trispecific field, is sorting that out. But I don't have more insight than that.
Yeah, I mean, that's also got a number of relatively complicated antibody engineering issues associated with it. We may learn from another field. If you look at something like oncolytic viruses, we're seeing viruses with 1, 2, 3, 4 different aspects to their payload. So in a different way, we may start to be able to tease out the relative contribution of multi-targeting in a slightly different domain, and then perhaps bring that back to this area. But I think the question has to be, what's the added value of the engineering and solubility and manufacturing complexities versus just giving some of the drugs in a more conventional way and sticking with bispecifics? And I think the jury is very much out on that at the moment.
I mean, I think the potential is there, but we really need to be really developing drugs that have an advantage than giving them in combination. But there are potential advantages to that because of spatial binding and also because of temporal binding one to the other. So through specifics, I think particularly engaging T cells can be attractive. We already know how there are different ways that combining are. So, I mean, I would argue yes, but of course we still need to see the promise of that.
Yeah, I think ultimately it gets us to the question of patient selection, getting back to Dr. Rini's point on which patient we want to have this approach. And therefore, there's both the approach of, picking the patient that have the high risk of very aggressive tumor and the one that have the higher chance to respond. So we're mixing both the approach of a prognostic definition of our patient population or predictive toward our response, and obviously we're still lacking that part as well.
And Dr. Schramm, I don't know if you want to weigh in.
Sure, yeah. I would just say that in terms of the difference between having it on one-off versus combination therapy, maybe specifically biology, you're trying to target two things is there a benefit of having that in your body, is there a benefit from a toxicity standpoint to not targeting them individually? So I think the biology of what we're trying to do could really influence whether just two drugs that accomplish the same thing as one drug engineered in such a way to spatially eat your body, if that makes sense.
So, well, thank you to all the speakers and discussants. I really appreciate your insights, and thanks to the audience for attending this session. Enjoy the rest of ASCO.